And thank you very much for the introduction and for the opportunity to speak to you. All of the investigators on Heal COVID are doing a wonderful job. I'm going to share my experiences of doing some trial work in COVID by telling you a bit about STOP COVID, but it's an enormous challenge under the circumstances of a pandemic to do a randomized clinical trial across the UK, and hats off to Mark and to Sharma and to all of the Heal COVID team for having done that so successfully. So I'm going to talk a little bit about STOP COVID, as Mark said, a little bit about inflammation in long COVID, and how that might inform some of the things that we're hopefully going to learn from the Heal COVID trial. I'm going to talk for hopefully about 20 minutes, so everybody gets their evening to continue. This is going to be a whiz through a little bit of some of our preclinical data that informed why we went for proteinase inhibition as a strategy in COVID-19, and then the results of the trial itself. So as a reminder, we now know that there's a substantial burden in the UK of people who have significantly impaired health status after COVID-19. And one of the largest studies and a collaborative study that I've been delighted to be involved in is the STOP COVID study, which is the national consortium that studies patients who've been hospitalized with COVID-19. And this has given us some really good data about the scale of post-COVID disease. So if we look at the results of that study, the study also identified the risk factors for long COVID, and these are actually some of the risk factors that are now consistent between both inpatient and outpatient studies, including being female, being obese, and having a more severe acute illness. So there's a real challenge now to understand the biology of why people are developing persistent symptoms and why SARS-CoV-2 in particular is more likely perhaps than other previous viral infections to cause prolonged illness. And so there's a strive to really understand the biology a bit better. Now, we're very interested in Dundee, as Mark was saying during the introduction, in the inflammatory response, but particularly in a type of inflammation driven by neutrophils, which are your body's main defense against bacterial infections typically, but they also have an important role in viral infections. And so we've done a study looking at people with acute and with long COVID, looking at the proteins in the airway, in the blood and in the airway, using a methodology called proteomics that profiles all of the different proteins that are there. So in this study, we took 92 people with COVID, 42 controls who were people who were hospitalized for things like cardiac disease, so they didn't have an acute viral infection, and 91 people with pneumonia. And we collected blood, isolated neutrophils, and then looked at all of the proteins by a very high sensitivity method called mass spectrometry to look then at what is changing in the inflammatory response in people that have got COVID or have got associated lower respiratory tract infections. And what you can see on the bottom here is what's called volcano plots. So these are plots that look at the degree of inflammation between the groups. And when you compare pneumonia with control, you don't see that many proteins that are changed. There are some, and there are some proteins that are very much associated with pneumonia on the right-hand side, but it's very different to this profound change in the inflammatory response that you see in people that have got COVID-19, where there's loads of proteins here that are greatly changed in the neutrophils. And remember, this is looking at the pure cells. So what we're seeing here is a very distinct inflammatory response associated with COVID-19, and it's dominated by some of these proteins that are part of the interferon antiviral response. And it's related to how severe the COVID is. So people who have WHO3, which means that they're in hospital but not needing oxygen, have only a few proteins changed, whereas thousands of proteins are changed in the inflammatory response in people that have severe COVID in the intensive care unit, which is what WHO 5 and 6 means. So we've dug into this a little bit deeper, and there are clear changes in the proteins on day 1, which is when patients are first admitted to hospital. But I'm going to focus your attention in these complicated graphs on the data at day 29, where there's a difference in a number of these neutrophil proteins between patients who are not recovered, meaning they have long COVID, and patients that have recovered, which is what's meant by WHO1. And these are in the receptors that line the neutrophil and allow it to respond to inflammatory signals, as well as receptors like CD11b, which are markers of the activation of the cells, how angry and upset the immune system is. And there's a clear difference there at day 29 between patients who are feeling better and patients that are not feeling better. And so we have a relationship here between persistent dysfunction of this very important part of the immune system across multiple different functions and the failure to recover. So patients from this data, we can say, have dysfunctional neutrophils right at the beginning of the COVID illness, and patients that fail to recover have persistent neutrophil dysfunction up to 1 month after COVID, which is beyond 1 month is where we start to talk about prolonged COVID illness. And of course, after 12 weeks, we start to talk about long COVID. And so we can think about this in terms of patients who have mild COVID predominantly don't have this neutrophil dysfunction, but patients who experience a more severe inflammatory illness have a persistent neutrophil activation, a persistent neutrophil dysfunction that may then place the patient at higher risk of complications. And indeed, a number of studies, the data on the right-hand side here is not ours, it's from other studies, showing relationships between markers of inflammation and severity of COVID, including the requirement for intensive care unit admission, but also complications in the liver, the kidney, and other organ involvement. And neutrophils make a number of enzymes that can be damaging to the host, including neutrophil elastase, and that is elevated in people that have severe COVID, as indicated by the red parts of the forest plot on the right-hand side of this slide. Of course, acute illness and admission to the intensive care unit is not the only complication of COVID-19. And indeed, we now recognize that patients are at higher risk of admission to hospital for other reasons, including an increased risk of cardiovascular disease. And this process whereby neutrophils release their intracellular contents, webs of DNA studded with proteins, has been shown to be an important initiator of the thrombotic response. So it causes platelets to aggregate, the formation of clots, and therefore an increased risk of cardiovascular disease. And that's something that we now recognize as an important complication of COVID-19, and is why anticoagulants are amongst the drugs that are being tested in programs like Heal COVID in patients post-COVID illness. So I hope I've persuaded you that neutrophils are probably very important, both in the first few weeks of COVID illness, but also probably post-COVID. So if we want to do something about that, we need to have some kind of drug that can target neutrophilic inflammation. And as Mark was indicating, a lot of my research pre-pandemic was focused on bronchiectasis, which is another chronic inflammatory disease, this time of the airways, of the bronchi. And in that disease, a drug called brensocatib has been developed, which targets an enzyme called DPP1 to disable the abnormal neutrophil response. So brensocatib works in the bone marrow as the neutrophils are being developed. So it blocks the activation of 3 enzymes, neutrophil elastase, proteinase 3, and cathepsin G. You don't need to remember all of that. But it blocks the activity of these enzymes that are involved in neutrophil activation and inflammation. By doing that, it allows neutrophils to then be released into the bloodstream that are otherwise normal, but are disarmed in terms of these damaging enzymes that destroy the lungs and cause lung injury. And we showed in a randomized trial published in 2020 in the New England Journal of Medicine that this drug could reduce lung inflammation over several weeks in people with bronchiectasis, and that it prevented exacerbation, so it prolonged the time to the first exacerbation. So it looks really promising as an anti-inflammatory drug in chronic lung disease. And so given the association between neutrophils and both acute and long-term COVID, we wondered whether brensocatib or DPP1 inhibition would also be an effective treatment in the context of COVID-19. And that led us to this study that was published just really last month in the Lancet Respiratory Medicine. And this is the STOP COVID19 trial, where we tested whether dipeptidyl peptidase 1 inhibition would be effective in people with acute COVID-19. So I'll tell you the results of that study now. This was a double-blind randomized placebo-controlled study. Many of the studies conducted during the pandemic were quite pragmatic in nature, like recovery. But for this, we went for the gold standard double-blind placebo-controlled trial approach. This was targeting people with severe COVID in hospital. So all patients had to be hospitalized. And we excluded people that needed mechanical ventilation because we thought that would be too late to modify the disease process. The primary outcome was World Health Organization 7-point scale. So that's a way of rating how sick patients are, going from 1 being they're at home and completely well to 7 being unfortunately death, and all of the factors in between. The secondary endpoints included time to clinical improvement, change in clinical status, oxygen, mechanical ventilation, and of course safety, because this is a relatively new drug. And it was conducted across 14 centres, with the trial finishing in January 2021. And this was designated as one of the UK's urgent public health studies, alongside things like recovery and REMAP-CAP. In total, we randomized 406 patients. 192 were randomized to brensocatib, 214 to placebo. 2 patients were included who actually shouldn't have been included because they didn't meet the inclusion criteria, and so they were excluded, leaving 190 in the treatment group for the final analysis. This is the characteristics of the patient population. The average age is 60. The majority are male, which is typical of the patients admitted to hospital during the first and second waves. And you can see the breakdown of the severity of disease here. Most patients were hospitalized needing oxygen. A small proportion, 10%, were requiring non-invasive or high-flow oxygen or CPAP. And around a quarter required no oxygen but were in hospital because they were sick or they were thought to be at risk. So we had a nice mix of severities in which to look at the effectiveness of the intervention. The average patient had symptoms for between 8 and 9 days, and that was typical of what we saw during that first and second waves. And patients had to have at least 1 risk factor for severe infection. And so you can see here the proportions that required oxygen, that had radiographic infiltrates, that had low lymphocyte count, etc. And they were required to have confirmed COVID, and you can see the vast majority had confirmed COVID with a PCR test. So now to the actual results of the trial. And here we got a bit of a surprise. So the hypothesis was that blocking neutrophilic inflammation would improve outcomes. And what we saw, in fact, was that there were slightly fewer patients in the brensocatib group who were not hospitalized and were at home, 14.7% versus 18.7%. And the mortality was slightly higher in the brensocatib group, with 10.7% dying in the placebo group and 15.3% in the brensocatib group over the 28-day study period. So in the adjusted odds ratio, which is the difference between the groups and the proportions in each of these categories, in fact, patients who are randomized to brensocatib did 28% less well, and that was statistically significant. So the primary outcome favored the placebo group, which was a surprise. When we look at the other outcomes, you can see the results for mortality at the top there, which you've already seen. This is the table taken directly from the Lancet. There was no difference in time to clinical improvement, no difference in the news scores between the groups, but slightly fewer oxygen-free days in the patients who were on brensocatib, so they used more oxygen is another way of expressing that. And slightly more patients required new mechanical ventilation. You can see that, which I'm highlighting with the cursor. Most of the other outcomes didn't show a difference. But the overall impression was that this definitely didn't improve outcomes, and some of the endpoints were going in the wrong direction. When we look at the subgroup effects, they're quite consistent, actually. So the overall effect is highlighted at the top here. Across the whole population, it's in favor of the placebo group. And when you draw the line down here, you see that age groups are pretty much the same. Male, females did pretty much the same. Patients did slightly better if they were CStat 3, meaning they didn't need oxygen, but there was no real difference between the groups. And duration of symptoms also didn't make a big enough effect for there to be a meaningful subgroup difference. So really, the conclusion here is across all of the subgroups, the results are consistent with the primary outcome. There were no major safety issues identified, so there's a similar number of adverse effects between the different groups. And you can see that on the table, again, taken from the Lancet publication on the right-hand side. None of the differences between the groups are really meaningful or statistically significant. Importantly, we didn't see an increased risk of infections in patients receiving brensocatib, because one of our questions would be, with the slightly worse outcomes, is an immunosuppressive drug increasing the risk of infection? But we didn't really see any evidence that that would be the case. So ultimately, no major safety issues identified. So that's the results of the study. Obviously, when a drug doesn't work, there's possible explanations for why a drug doesn't work. Would be that you had the wrong mechanism, but another is that you just didn't give a high enough dose, or the drug didn't have the pharmacological effect that you were expecting it to have. And so we did look at that within this study. We looked in quite a lot of detail using an exploratory sub-study where we took blood from patients at baseline, day 8, day 15, and day 29 during hospitalization for COVID. And we actually brought patients back at day 29 in order to do the follow-up. And you'll be pleased to know, I'm not going to show you the results of all of these basic science interventions, but we did quite a lot of profiling of how the neutrophils were working. We isolated the peripheral blood mononuclear cells to look at their proteins. But importantly, we looked at stimulation of the blood with an inflammatory stimulus called zymazan to see whether the drug, which is an antiproteinase, was reducing protease levels within the blood. And that's what I'm going to show on the next slide. This is a very simple experiment where blood from the patients is stimulated with what is effectively a fungus, or something that's pretending to be a fungus. It causes the neutrophils to spit out whatever is inside them, and you can then measure what they release through measurement of neutrophil elastase activity. And this is the result. What you can see here is that there's a difference between the groups by day 8, meaning that the drug is having an effect. By day 15, there's a very clear effect, and that's sustained through the study. So the drug did what we expect it to do, which is to reduce neutrophil serine protease activity. So the lack of efficacy was not the drug not doing what we expected it to do. This is now looking at protein levels. It doesn't reduce the amount of elastase, it just reduces the amount of active protease. And there was no effect, again, on either of the major proteins that are made, the major proteases in terms of the amount of protein. It just reduced activity. So it did exactly what we wanted it to do. It just unfortunately didn't translate into clinical benefits for the patients. So that is the result of a huge amount of work from a large number of people, but ultimately a trial that was negative. So we showed very clearly that brensocatib reduced neutrophil elastase, but that didn't result in clinical benefits for patients with COVID. We have shown within this that there's changes in some of the neutrophil functions, but most of those would be expected to benefit the patients rather than to cause either difficulties or failure of efficacy. And so we remain from this trial unclear why blocking neutrophils didn't result in a significant benefit. And there are some additional data that we've generated suggesting that the drug may have other anti-inflammatory effects that may benefit patients with bronchiectasis or some of the other indications for the drug, but clearly not going to be a treatment, unfortunately, for COVID-19. So we remain, I think, very interested in what the inflammatory process is doing in long COVID and the role of neutrophils, but we'll need to think very carefully about how we target that, since in this study, blocking a neutrophil serine protease and a series of serine proteases did not result in clinical benefits. As I said at the beginning, doing these trials, particularly during a pandemic, is incredibly challenging. And I'm extremely proud, despite the negative results, of the team that delivered the study and all of our collaborators across the UK, and also the team in the lab that did the translational science, which was embedded within the trial and has helped us to understand the data and to plan what we would do in further trials. I would finish again by saying thank you to the sites that participated. And I know how much Mark and Charlotte and the team appreciate all of the work that's going on across the country as we continue the challenge of trying to find new treatments for COVID in HEAL COVID, which is a phenomenally important study and one that Mark and Charlotte should be very proud of. Thank you very much for inviting me to speak to you. And again, congratulations on all the work on HEAL COVID. Thank you.